That name has to be approved.
We are live now. Good evening, everyone. Welcome to another episode of the masterclass brought to you by the Academic Council of IASO. I welcome you all from me and the convener, Dr. T.S. Rao. We invite our IASO President, Dr. Rajendra Dobrani, to kindly give the welcome address for the session. Sir.
Thank you, Srijan. Thank you, Dr. Rao. At the outset, let me welcome you all the IASO members, to this another episode of IASO Academic Masterclass series. And we had a fantastic meeting at Shillong, the midterm meeting, where we had more than 300 registrations. And a lot of youngsters came and presented their abstracts. So this time we selected the topic of oropharyngeal tumors. There has been a great paradigm shift of management of oropharyngeal tumors this last more than 30 years now. Initially, when we were residents and trainees, we used to operate all those patients in surgery. Then came the era of chemoradiation. And then there was this HPV era. In India, however, we see less HPV patients. But again, there is a role of, with the advent of robotic surgery, there is a role of minimal access surgery for selected patients. So let us hear from the experts. Let the examiners ask difficult questions to the students, and let us learn from them. So over to you, Srijan.
Thank you, sir. Our examiners for today, the first session will be moderated by Dr. Arvind Krishnamurthy, who is the professor and head the Department of Surgical Oncology at Cancer Institute, Adyar. He'll be joined by Dr. Surendra Dabas, who's the senior director and head of Department Surgical Oncology and Robotic Surgery at BLK Max Super Specialty Hospital, New Delhi. He's been a mentor to many in robotic surgery, and his interests include head neck oncology, TORS, robotic GI, thorax, and gynec surgeries. They're joined by Dr. Deepappa Nair, who's the professor and associate surgeon in the division of head and neck oncology at Tata Memorial Center. Her areas of interest include management of skull-based malignancies, minimally invasive head and neck surgery, HP negative oropharyngeal cancers. She has multiple publications in national and international peer-reviewed journals, and also has authored 5 book chapters. The examinees for today are Dr. Rohit Mundra, who's a senior resident in the Department of Surgical Oncology at TMH Mumbai, and Dr. Oindrila Biswas, who's a resident in Department of Surgical Oncology at Yenapoya Medical College, Mangalore. The first session for 60 minutes would be a mock exam, in which our request to the examinees is to give to-the-point answers to the questions being asked. It's never ever expected that you would know all the answers, so there's no harm mentioning that if you don't know something, because it saves us time and it maintains the flow of this webinar. Our examiners do have the habit of giving hints. It's up to you to catch it. For our dear examiners and moderator, in interest of the online viewers, both who are live here on YouTube live, as well as the people who are viewing it on the YouTube later, we request you to give the expected answers to the questions that have been incorrectly answered or remain unanswered. For our participants, the senior ISO members in the meeting, we appreciate your participation, and we request you to post in your inputs as well in the chat box. And for the residents, it's a unique opportunity to clear all your doubts before the coming exam season. I'll be reminding the moderator at 30 minutes and at the conclusion of the case discussion. Over to you, Dr. Krishnamurthy. You may share your screen and take the proceedings forward.
Yeah, good evening, everybody. the outset, I would like to thank the leadership of the IASO and the academic council of the IASO for the wonderful initiative that they've been doing for a long time now. And I've also attended some of these webinars. I myself have benefited from them. And today's topic is a little challenging topic. Normally, it's not given as a regular case, barring the, say, MCH head and neck surgery. But nonetheless, I must tell you all, that's a very, very exciting field. It's one of the hot topics in head and neck oncology. If you go to any sort of, conference or any meeting worldwide, I must say more so. So this is a very important topic. And also the fact remains that the pendulum in oropharyngeal tumors have swung a long way, right? From 1990s onwards, it was surgeon dominated, then chemo-RT came, then in 2009, robotics came. So, and of course, the other aspect is the issue, the other issue is that there are very few robust evidences. So I guess, what happens is there may be a divergence of opinions, but nonetheless, we have got two expert examiners, Dr. Dabas, who has actually proctored me a little bit in robotics as well. One of the finest robotic head neck surgeons I have seen. And I think he has done a lot of work. He has published a lot, and we would look forward to hearing you during this session, also from the subsequent session, and also Dr. Deepa, from TMH, very level-headed to what I know. I'm sure that now you will give the balance in case the argument is swayed one way or the other. And to the two examinees, I guess, Dr. Indrila and Dr. Rohit, I really appreciate your volunteering to sort of to come, and let's have some sort of wonderful discussion. So I will get started right away. And this is the first case, a 52-year-old lady, fit lady in a performance status 1. She just complains of a sore throat for a couple of months, occasional difficulty in swallowing. And this is the picture. Of course, in times of COVID, it's sometimes very difficult to sort of, put in your the camera inside the oropharynx and see these patients and take this one. That's the reason why I gave a magnified view of this. And more importantly, I think we must actually be familiarized ourselves with this anatomy. So this is the, I'm sure you can see the lesion over here. This is the uvula. This is the anterior fossus. The lesion is there approaching the uvula and little bit going on to the tonsil. So what is the other history that you would like to ask? And maybe I will ask the lady first, Dr. Indrila. You can sort of, start off, and Rohit, you can sort of, chime in later.
So first, in the patient particulars, I want to know that which part of the world the patient belongs, like the western or eastern. That would I look for the patient particulars. And also as the lesion, I can see here, it is mostly involving the soft palate region. So being oropharyngeal malignancy, I would like to ask whether she is a smoker or not. And if she is a smoker, then how many packs a year she smokes, whether there is a history of alcoholism is there or not. And also there is any high risk behavior in terms of orogenital sex history is there or not, that I'd like to ask the patient.
Wonderful. Dr. Rohit, any other thing you want to sort of chip in?
I would also like to go with the same history, sir. History of smoking.
And anything to add from what Dr. Indrila sort of,
So maybe the symptoms more, if any otalgia is there or any refer pain, which that may be the addition.
Right.
And any neck swelling is there along with it. Is she complaining about any neck swelling along with the same thing?
Right. Dr. Indrila, you mentioned about east or west. Like, any thoughts on that? And maybe Dr. Deepa can sort of chime in later on that. Any particular reason that you want to sort of say for from east or west?
Yes, sir. Sir, Western population, there is a new emerge of HPV infection in the oropharyngeal malignancies. Whether the eastern world still there is higher chances of smoking induced, like tobacco induced oropharyngeal malignancies. So it again differentiates between the risk factors according to that, like HPV infection is there or not. So in that term, I would like to know which part the patient belongs to, which part of the world.
Right. Yeah, you mentioned pack years. Can you just define what a pack year is, Dr. Anju?
Yes, a pack here is in Indian scenario, it is 10 cigarettes per packet it contains. So if a patient smokes 1 pack per day for a year, that is counted as a 1 pack here. If 5 cigarettes per day, then it will be counted as a half pack here, like that.
Something, no, sometimes it is, I know, sir, sometimes they say 10 cigarettes, some literature says 20 and all those things. So
Yes,
I guess, you can be a little liberal on that. But anything else in regard with regards to pack years, like, why is it significant in this, like, it's a very important history, at least in head and neck, and more so in oropharynx. Why do you feel that pack year is important? Any particular cutoff in terms of pack years that you're aware of, Dr.
Yes, sir. According to RTOG 0129 trial, they have divided the oropharyngeal malignancy associated with HPV into high risk, intermediate risk, and low risk. And according to the definition, if it is less than 10 pack per year, it is counted as a low risk. If it is HPV positive but more than 10 pack years, then it is counted as an intermediate risk. And if it is HPV negative and greater than 10 packs per year, then it is counted as high risk. So in that way, it will help.
Wonderful, wonderful. I'm so happy that you really are giving answers. Deepa, you wanted to chime in anything, any particular aspect on this with regards to the history?
So she talked about high risk sexual behavior. Do I direct my questions only to her, or I can direct it to the person as well?
No, I think Rohit also you can give your
so Rohit,
your examples.
High risk sexual behavior. There is a trial, there was a study by National Health and Nutrition Survey by the American in the 5,500 patients, where they found that a sexual behavior can increase the risk of HPV positive cancer. But Creamer et al. In their study could not prove this, where the orogenital behavior of excessive orogenital sex was not correlated with the HPV positivity as compared to the general population. So, though we consider that high risk sexual behavior is a risk factor for HPV positive cancer, there is a dichotomy on it.
Do you know about how any data with respect to the number of partners or the time period for acute infections to be correlated with the history of oropharyngeal cancer?
Ma'am, it is greater than 6 orogenital sex partners and greater than is equal to 26 vaginal sex partners. That is counted to be higher risk in oropharyngeal malignancies.
Yeah, so again, this high risk sexual behavior is more correlated with males rather than for females, and very rightly the data is quite skewed between various studies. The study which quoted 26 vaginal sex partners was looking mainly at male patients who develop oropharyngeal cancer rather than female patients. So good points to bring about. Again, recent infections are more likely to be manifest. So the history of high-risk promiscuous sexual behavior in the last 3 months is more relevant rather than long-standing history of maybe 20 years before, is one of the other theories which is proposed.
Yeah, and just to add to what Deepa also said, like, it's a general thinking. Like, what happens is that human papillomavirus infection generally tends to be there in about if you see oral rinses, about 7% of the population would have some sort of HPV presence, but about 3% of the males and 1% of the women would have in a normal population itself. But what happens is a majority of them tend to sort of clear the sort of virus, and only a minority of them who sorts of carry it for many years, they sort of so that is also another issue, that any other point that you'll have to make in count. The other aspect is about mouth opening and trismus, like that is also very important. Any thoughts, Dr. Rohit, on this? Why is it important?
So in a case of tonsillar cancers, when if the trismus is there, it means the involvement of mastication muscles got involved, and that is means that it's an advanced cancer and not in other. So that way the trismus is important, but it's a late sign in the case of especially in the case of laryngeal tonsillar cancers where it is a lateralized cancer. And
any other implication of trismus?
Yes, sir. Trismus actually directly upstages a disease from T3 to T4. And secondly, if we are planning surgery for this patient, like any transfer robotic surgery, so that also is accounted in that part, sir, planning of the surgery. It is difficult to go for a patient with dots with trismus.
No, but T3 to T4, Dr. Dabas, you wanted to add anything on the trismus point?
So, Dr. Viswas is rightly said, if you are planning any surgical intervention, you need a good mouth opening. But I don't know how she is saying that it will upgrade the stage from T1 to T4. That's not because of trismus. But yes, if the patient does not have a good mouth opening, even I think if you have submucous fibrosis, the radiation effect will be less. And if even you want to go for salvage surgery and with trismus, then you cannot do it with transfer robotic surgery. Then you need mandibular swing approach for these patients, and outcomes are not so good.
Great points, Dr. Dabas. I think as is rightly said, trismus can be because of many reasons. No, because of oral tobacco use, you may have submucous fibrosis, or it may also be because of the involvement of some of the other masticator sort of muscle. So it doesn't really sort of upstage directly. Deepa, you wanted to add anything on this aspect of trismus?
Exactly. My point we should not forget that yes, HPV positive oropharyngeal cancer is rising in the Western population, but in our population, smokeless tobacco use is still the predominant underlying etiology. And the trismus, long-standing trismus should be ruled out compared to a recent onset trismus. So additional points or marks as a student would be given to you if you had talked about recent onset trismus rather than just trismus as a whole. Upstaging of disease due to recent onset trismus would carry more weightage rather than just trismus as a whole, because most of our patients will have OSMF.
And sometimes because of pain also associated, they may also not want to sort of it becomes slightly difficult. So it is a multifactorial. The other issue is with regards to, say, depth of invasion. You find a lot of mention about at least the depth of invasion in oral cavity cancers. Like, what is the significance? Maybe Dr. Antla, does it have any significance at all in oropharyngeal cancers? What are your thoughts about it?
No, sir, it is not included in the staging system, sir, depth of invasion in oropharyngeal cancer.
Right, Dr. Rohit?
HPV positive cancers also didn't show any relation with the depth of invasion, as well as the ENE also in the neck.
Right. So yeah, the point to be noted is in oral cancer staging, the entire scenario changes in a clinical examination. In oropharynx, generally, clinical examination per se is sort of very less you can do. Like sometimes, how do you sort of examine these patients in your outpatient? Supposing some of these patients come to your outpatient with, say, a mass or something of that sort. How do you sort of what examinations do you do in your outpatient?
So I would like to divide the examinations in an office based in a OPD basis, and the examinations which will be done later inside the OT. First, when we examine with the patient comes with these complaints, I would like to give a detailed oral examination along with the indirect laryngoscopy, and if availability is there, I would like to do video endoscopy also. That's Hopkins examination, so that I can where exactly is the site of disease and where it has spread from the, at least on an office base, I can know. And also I would like to examine the neck for any involvement of the neck, any neck nodes are involved or not.
Right.
This is one is office based. Secondly, after the once this examination over, I would like to map the disease better. I would like to examine the patient under examination under anesthesia. And also I would like to do a direct laryngoscopy.
So do we do it in all patients?
So in early cancers, when I am sure about an office space, I would not like to do an examination under anesthesia. But in when the locally advanced cancer is there, I would like to do it in oropharyngeal cancers.
Dr. Antla, you want to chime in here?
Examination
Anesthesia?
Yeah, examination under anesthesia, usually we avoid in two scenarios. One is the patient who will not tolerate the general anesthesia, of course. And also the second scenario is where the EUA will not change the modality of treatment. In that scenario, we won't do the examination under anesthesia.
Dr. Dabas, you wanted to sort of know how frequently do you do examination of under anesthesia? Of course, when you are taking the patient for surgery, you would sort of do it, but you do it as a separate sort of procedure. How was your practice, Dr. Dabas?
Praveen, you rightly said, if you are planning surgical intervention in these patients, you always do EUA, but we are not doing it separately. We are doing EUA and then proceeding to surgery if it is resectable. But now your patient is coming to you with the locally advanced oropharynx, then, and we're sending the patient to chemoradiation, then we don't do EUA in these patients. But surgical patients require EUA before planning surgery. And mainly, I will say base of tongue cancers, because sometimes when you're doing a laryngoscopy, you cannot evaluate the base of tongue involvement very nicely with direct laryngoscopy. For tonsillar cancers, is fine. They have a limited space, but based on tumors, we always require EUA before proceeding to surgery.
Dr. Deepa, what has been your practice and your
So I agree with with Dr. Dabas and Andrela. I just want to add a point here that examination, rather than just a flexible mapping, is always some sort of examination is always better, because the MRI tends to overestimate disease. If you remember, the MRI is not it's just a static image. So there's a lot of overlap in terms of the base. There's no movement of the tongue. So sometimes you feel as if the disease is very close to the higher than the MR, but it's just an overestimation or volume effect. And that can be actually seen better when you examine the patient under anesthesia, or even just do a flexible and ask the patient to protrude the tongue, and actually you see the vallicula is free, whereas on the scans, the vallicula seems to be involved. So it has to be correlated with a good clinical examination, endoscopic evaluation. A Hopkins is not my preference of choice, because again, in a Hopkins, you're making the tongue very taut. So especially for base tongue lesions, you may miss out on important information by doing a Hopkins examination. A flexible examination is much better.
Great points. I think what happens in generally in any other cancer, they divide into inspection, palpation, and all those things. But in case of oropharynx per se, your inspection, you just sort of see maybe some tonsillar bulge or base of tongue bulge, or there's hardly or your uvular position. That's all you would see. But a lot of times, I think, as Deepa said, I think ask the patient to open the mouth, protrude the tongue, and sometimes say an ah. Like, at that time, and definitely some sort of digital examination would sort of be required to, especially as Dr. Dabas said, in the base of tongue tumors. Sometimes you would sort of have this. Okay, now anything? Can we move on, Dr. Dabas, Dr. Deepa? Any other points in history or?
One point I was telling of the depth of invasion. So we have a lot of literature of DOI in oral cancers, but we don't have any evidence of DOI in oropharyngeal cancers. So what we did, we studied around 50 patients of tonsil and base tongue in our paper. And surprisingly, like in oral cancers, DOI is related to the involvement of lymph nodes. But in oropharynx, we were not able to correlate DOI with the lymph node metastasis. Maybe the tonsillar fossa, base tongue, they are type of static structures as compared to oral tongue. And we are doing more work on that. But in 50 patients, we were not able to correlate with the level of lymph node metastasis in oropharynx.
Right.
Can I just make one point?
Yeah.
I don't know how
relevant
it is here.
Yeah,
I think HPV positive oropharyngeal cancers, your HPV, you actually see the HPV growing in the crypts. So again, their depth of invasion is a bit fallacious, because unless you really sample on pathology the specimen properly, you may misinterpret the depth of invasion because the seed of the tumor is in the crypts, but the whole crypt tonsil looks involved. So that's just a point, but it's more academic.
Yeah, great point. I think that is also one of the reasons why you don't actually diagnose early oropharyngeal cancers, no? Because what happens in, unlike in oral cancers, no, the lesion actually starts in the lower crypt and slightly deeper. So sometimes, like, in cervical cancers, when you can do a PAPS cytology and do a brushing to get, but in case of oropharyngeal cancers, you will not be able to get, exactly for those reasons, because most of these lesions are slightly deeper, and they will not be amenable to a cytological diagnosis. So early diagnosis is a little fallacious, and also the fact that in cases of HPV positive, you don't get an in situ carcinoma, but of course that there is a lot of work in progress because of this. I think great point, Deepa. Can we move ahead? We have a couple of more cases to discuss, and I'm sure that other issues we can. With regards to the imaging, I've got two other cases. In this case, I would say probably we can just quickly go to the management aspect. I must tell you that in this case, it was just a 3 into 2 centimeters lesion, left side of the soft palate, not reaching the soft palate. There was a distance of about 1 centimeter, extending into the anterior fascial pillar. An outside CT was there. We did an MRI, and there was absolutely nothing to actually show. Very little limited thickening. All the spaces were all normal, no lymph nodes. And maybe how do you proceed, Dr. Rohit?
So first, I would like to do a biopsy of the lesion.
Right.
First, find out along with the biopsy, I would like to do a HPV status. Surrogate marking P16 can be done first.
Right.
Then, according to the biopsy of the lesion, I will be able to characterize it better. I will be able to stage it better. And since there is no neck nodes on scan, so it is N0 to start with. It's a
right. Dr. Angela, you wanted to add anything?
Yes, almost the same. I'd like to go for a biopsy for this patient, and also would like to IHC for the HPV P16 marker. And also, I would like to know the next status of the patient, which is mentioned as N0. So no further imaging investigation I would like to do. But here, sir, P16 negative query has been kept, sir. I didn't really understand.
No, that's because I just wanted it is negative only. Yeah.
Okay.
It is.
Then,
P16.
Pardon, sir?
Dr. Arvind is asking you guys why you want to get P16 done on this patient.
So in the biopsy, it is mentioned as keratinizing. Normally in the HPV patients, the morphology will be non-keratinizing. It's a poorly differentiated. It will be poorly differentiated. But that was not available that time. So that's why I told that I would additionally, I would like to do P16 that.
So what information you will get from P16?
Yeah, go ahead.
Pardon, sir, again, sorry.
How is it going to help you in P16 is going to help you in deciding your treatment options, prognosis?
So P16, if it is positive, then it is. I would like to do HPV Dna also, because to concordance is about 83% with P16. But when HPV Dna plus P16 is both are positive, we are sure about the HPV status of the patient. When P16 is negative but HPV Dna is positive, we still consider that patient as a HPV positive. And once we know we have a HPV positive status, according to AJCC 8 classification, HPV positive and HPV negative are staged differently, and accordingly the treatment may differ.
Great point. So, Dr. Rohit, if I may ask you, do you reflexly do P16 and HPV for all your patients of oropharynx?
No, so when the P16 is positive, we usually may not do HPV Dna, sir. It's like 83% concordance is there, so we usually consider it as HPV positive. But
no, let's talk about clinical practice. Like, what is your regular clinical practice?
So in Indian scenario, we may not have many HPV positive ones. So when the biopsy is there, assessing, we usually don't do.
No, you're right, because there are a lot of points and a lot of literature also to suggest that, there can be a P16 positive and a HPV negative also, which may have a different connotation. But I was just wondering, like, what is, Dr. Angela, what is your practice? And maybe I can just ask Dr. Abbas also, what is his thoughts on?
Yes, sir. In our setup, if P16 is positive, it is taken as positive. And if it is negative, then we can go for, along with ISA, we can go for the ISH also. Because both the modalities, when it is used together, it increases the sensitivity of detecting the HPV. So I'd like to go for both of the modalities in this setup.
So how you get Hpv DNA done? How you detect that? Rohit?
So HPV DNA, we can detect by there are two methods where we can detect, like either with the in situ hybridization or a PCR technique. In situ hybridization has a 100% specificity rate, while and secondly PCR technique we can use, which is more office based, more simpler to get as compared to in situ hybridization, which is a more difficult technique as compared to PCR.
So what is the supposed gold standard?
Gold standard?
Sort of, I guess there may not be a perfect gold standard, but
theoretically we should ask here.
Sir, it is better when we do the both modalities together, but ISH has a better sensitivity than the P16.
No, it is actually this is more theoretical, but E6, E7 mRNA by RT-PCR would sort of be the gold standard. But then you're right. I think both of you, of course, what happens in normal clinical practice, we may sort of differ in doing the HPV testing, but more and more guidelines, CAP guidelines, the UK guidelines, and all, they also suggest to sort of do some sort of a HPV testing in addition to your P16. But Deepa, what is your sort of take on this, and what is your regular practice, and then the guidelines we can sort of discuss over it.
At TMH, all oropharyngeal cancers will undergo P16 negative testing. And if they are P16 positive, they're regarded as HPV positive. We know that there's an incidence of false positivity, but for our clinical treatment and purposes, since it's not going to majorly alter treatment, we just do P16 IHC for documentation and staging.
Perfect. Right. Yeah, that's exactly the point. So that has also been given in most of the sort of guidelines. I know that there is some ASCO guideline that suggests that you do some HPV testing also. But in effect, what you both have told is very good, because there may be a lot of false positives and false negatives also. And there is a lot of growing literature to suggest that patients who are P16 positive, but who are HPV negative, now these patients actually do worse than the others. So there is a lot of emerging data to this, but I think for now, based on a lot of these, the TNM staging and majority of the guidelines, we would possibly stick to P16 immunohistochemistry as a surrogate marker. Any quick thoughts on why P16 they are doing? Any quick thoughts on the carcinogenesis mechanism, and then subsequently we can move to the management? Why do you detect P16? How was P16 overexpressed? What is the relation of P16 to HPV?
So P16 is a tumor suppressor gene, actually is overexpressed in the HPV, which acts on the CDK4 and 6, which actually is a,
Tumor suppressor genes are different. They are P53 and the RB.
Yes.
Yeah? Okay.
So usually HPV E6 binds to P53 and E7 binds to RB gene, and they get both get suppressed. And the pathway which usually is followed is P16 pathway for a.
Perfect. I think it's perfect. I think that you can read about it. It is E6 binds to P53, E7 binds to the RB, and then there is some amount of cell cycle amplification, apoptosis, and then subsequently P16 gets overexpressed. And that's why, as a surrogate marker, you do. Coming down to this case, it's a soft palate, predominantly. It's a P16 negative, T2 and 0, M0. What is your take on the modality of treatment? Dr. Angela, and then.
Sir, I would like to classify the patient according to low risk, intermediate risk, and high risk. And if the patient comes in
He's
low
a
risk,
non-tobacco user, let me tell you, sorry.
yes, sir. Then patient will come under low risk category in this intermediate risk category in this case. So I would like to offer this patient surgery in first of choice as a treatment modality. In terms of transoral robotic surgery, I would like to offer if it is available in the institute.
Right. So any other alternative, Dr. Or that is the only thing you would sort of offer?
So chemoradiotherapy we can go for, sir, but both the modalities has pros and cons on its own. So if possible, I would like to go for transoral surgery for this patient as it comes under a low risk.
So Angela, you want to do transoral robotic surgery for the primary lesion. How are you planning to manage the neck in this patient?
So, ma'am, neck will go for elective neck dissection for this patient in terms of level 2, 3, and 4 lymph node dissection on this side.
This is a soft palate lesion. In soft palate, you tend to have early bilateral nodal metastasis. So would you consider doing a bilateral neck dissection for this patient?
Rohit and
So, since it's a soft palate lesion, first to go ahead with the TORS was a bit of velopharyngeal insufficiency increases with the surgery. I would like to go ahead with the RT alone. Base of tongue and tonsillar regions, I would more likely to offer TORS. Secondly, for a nerve, yes, I would like to go ahead with a bilateral neck dissection, but this was a lateralized lesion, but still I would like to go ahead with a bilateral neck dissection, but level 2 to 4.
Yeah, great. I think there is a consensus that you're going to, for surgery, only lateralized tumors you tend to do unilateral, but anything which is even base tongue, sort of, palate, soft palate, postopharyngeal wall, you tend to do a bilateral. But Dr. Angela, you mentioned chemoradiation therapy. Why did you sort of tell chemoradiation as an alternative? Like Dr. Rohit mentioned radiation therapy alone. You wanted to give a chemoradiation, so that I just wanted to check your philosophy there.
So addition of chemotherapy will increase the better outcomes, sir. It will increase the outcomes, sir. That's why I wanted to add chemotherapy for this patient along with RT.
Right. So after the surgery, if there are some high risk factors such as the margins are close, means it's intermediate, or a positive risk like margins are positive, or maybe ENE is present, or maybe the node more than one lymph node, but more than one lymph node, but high risk factors more than one lymph node is positive, then I would like to go ahead with a addition of.
Right. No, the general dictum, I just wanted to say, this is say stage 2 or something. So general dictum in head neck cancer, stage 1 or stage 2, you tend to use one modality of treatment. Of course, you did mention, Rohit, the adverse factors. I very well agree to it. Based on your final pathology, you would sort of add some degree of treatment based on certain adverse factors. So that's the thing. So maybe either your consideration would be surgery or possibly radiation therapy alone. I think that's the better. What is your choice?
I have a doubt here. So is it in a soft palate? TRS will
let Dr. Dabas answer it. No, I just wanted him to sort of have your take, because you had certain reservations about sort of velopharyngeal insufficiency, and very rightly so. You did mention about it, so I just wanted to take Dr. Dabas's view on this.
Arvind, if I'm planning any TORS surgery for oropharynx, soft palate is my last area where I want to do TORS. The reason is one, it is exposed. You can do an endoscopic surgery or laser surgery because the palate is, you can see directly. But I always say, if you want to train yourself into robotic surgery, oropharynx, palate is the first area where can you resect and see all your movements. moments of the instruments, and you can do surgery in soft palate. But till now, I have done only 5 or 6 TORS surgery for soft palate. The reason is that you have a lot of morbidity. The one is valvopharyngeal incompetence, nasal. So patients are not very comfortable. Again, if I plan surgery for this patient, I would like to go for a flap reconstruction for this patient. And again, as Deepa was asking of the neck dissection, so it is N0 neck. So I will do an epilateral neck. And if there are no significant lymph nodes on same side, I will not do a contralateral neck. I may avoid that. One more point is I would look for RP lymph nodes, retropharyngeal lymph node in soft palate. One of the most common site for retropharyngeal lymph node. I don't know MRI. MRI may show lymph nodes, but I would like to go for PET CT in soft palatal tumors to detect retropharyngeal lymph node, because my patients mainly fails in retropharyngeal lymph nodes. If I'm doing only surgery in these patients, no radiation, we are not covering retropharyngeal lymph nodes, so they fails in retropharyngeal lymph nodes. So if I want to go for surgery, I will go for flap reconstruction, one. Right. Neck action on same side, opposite, if same side is positive. Right. Would like to avoid surgery, but will do surgery only when patient is a salvage patient.
Right.
Or patient is not willing for coming for 35 days continuously in the hospital. Patient says, I want to go for surgery, then I will say yes. Because curative wise, surgery is better than radiation, no doubt about that. Right. In palatal tumor, radiation fails very badly.
So, yeah, Dr. Rabas, great points. I think you really mentioned that, that for a beginner in robotics, I think this is one thing. Of course, in this case, this was going slightly into the tonsil as well. And your point of retropharyngeal nodes are also well taken. And with radiation as a modality of treatment, you can possibly sort of, cover the RP nodes as well. Dr. Deepa, your quick take on this, then we can move to the next case.
Actually, I have 2 questions to the.
Right. Go ahead, Deepa.
Mute. Dr. Deepa, you are mute.
Yeah, sorry. So one is for Rohit, and that is, you said radiotherapy would be an option. What sort of radiotherapy would you plan for this patient? And for Oindrila, you're planning surgery for this patient. You want to do an ipsilateral neck dissection. Is there any modality of something which is under investigation now to avoid contralateral neck dissection?
Ma'am, frozen section we can send for this patient to know the N0 lymph nodal status. And also for N0 neck, the recent upcoming modality is sentinel lymph node biopsy.
Excellent.
Very good.
So there's a lot of role for sentinel node biopsy for oropharyngeal tumors, specifically for this, to reduce the morbidity of neck dissection and contralateral neck dissection in patients. So excellent points, Andrila. What about you, Rohit?
So, ma'am, I would like to give a definitive RT about 75 gray.
Modality, Deepa.
RT alone only.
Yeah, I agree. That
I am RT based modality.
Yeah. Okay.
Because
so you must specify that.
We have now papers which have shown that IMRT has decreased the toxicity level after which was there with the EBRT, especially with the dysphagia and quality of life.
Is there any other localized radiotherapy which you can offer patients, especially
brachytherapy can be offered, ma'am. So usually previously it was a EBRT with a brachytherapy boost was used to get offered to the primary. We can still offer that also, but with IMRT, with the IMRT and IGRT, we may go ahead and offer that.
So excellent. Just a point to note that especially for T1 soft palate cancers, brachytherapy is a good treatment choice where you give a high dose to a small area in a very small limited time. So these are the 2 questions which I wanted to ask. My take on soft palate is, again, because of the velopharyngeal insufficiency, even if you reconstruct with a soft tissue flap, it's never a functional pharyngeal closure. And my choice would be radiotherapy for most soft palate lesions.
Deepa, the patient shown by Dr. Arvind, if you give radiation therapy, this patient is going to have velopharyngeal incompetency even after radiation therapy.
But it's for superficial lesions, at least in our setup, we've not had so much bad adverse results in soft palate. But I think that is a matter of
photograph. You can see the contracted soft palate, and they're not going to have a relaxed palate even after radiation therapy.
Maybe ISO can have a debate with the Dr. Deepa and Dr. Dabas separately, I think, on this. I told you this is
I'm saying it's radiation therapy, but the patient you are showing in the picture, you can see the contracted soft palate. Patient will have velopharyngeal incompetency even after radiation therapy.
Yeah, great. No, we actually operated on this patient. We sort of, because as I said, it was a very superficial sort of a lesion, and we went ahead with TORS and like palatal neck dissection for this patient. But again, there are both the options are there, and ideally you can discuss it in a multidisciplinary tumor board, take the patient into confidence, look at other factors, and then take a call. The other thing is, if you're with regards to the margins, say in general, like Dr. Rohit, what is your margins for transoral robotic? What is the philosophy of margins?
So 5 mm margin is adequate in a case of transoral robotic surgery. We usually would like to do a frozen section. There are three. We may do a frozen section compulsorily, which has shown the lower negative rate, which as compared to HPR, or we may even choose to do frozen in some and frozen not doing a frozen in some. But usually, I would like to do a frozen with TRS when we do and find out the margins under the door.
Right now, 5 mm is a safe bet. Dr. Angela, any thoughts on that?
Sir, it is 5 mm. What I know is it is 5 mm.
Right.
Does the HPV status change your margins?
Right.
HPV status 3 mm is adequate, because less than 3 mm would be intermediate risk, and for with more than 3 mm is compared as a CEPHO.
There are various trials that have taken different margin cutoffs, and of course HPV status is also in consideration. And that's what Deepa asked. Dr. Antila, anything you want to answer Dr. Deepa's question with regards to HPV status and margins?
No, sir. Sorry, sir. I'm not aware of it.
No, generally the dictum is for a HPV negative. The 5 mm rule would sort of be there, because it would sort of it'll be a sort of a high risk in a way. In case of HPV positive, a lot of trials have actually looked at slightly lesser margins, and as Rohit said, 3 mm, 5 mm. Maybe Weinstein's group said about 2 mm. Dr. Dabas, and your take on margins, sir.
So, Dr. Arvind, I will divide it into palatal tumors, tonsillar tumors, and base tongue tumors.
Right.
Palatal tumors, very difficult to take. You can try macroscopic 5 mm margins, but it is the one thing which contracts immediately, and you will have microscopically less than 3 mm margins. Right. Again, for tonsillar tumors, you can take out the full tonsillar fossa. The only issue in tonsil is the deep margin. So deep margin is what we read is superior constrictor muscle. It should be free of tumor. And if you see the anatomical detail of tonsillar fossa, there is a very avascular plane between the superior constrictor and the fascia of the medial pterygoid muscle. And if you have free margins there, so deep margin, okay, is free margin, maybe 2 mm, maybe less than 2 mm. You cannot take more than 2 mm deep margin in tonsillar fossas. But now when you come to base tongue, at least you should have 5 mm microscopic free margins in HPV negative cancers. HPV positive I'm talking about, but even in HPV positive, in our scenario, who are heavy smokers, we again attempt 5 mm microscopic margins for base tongue tumors. I'm not saying HPV positive 3 mm, HPV negative 5 mm, no. All oropharyngeal cancers, basically base tongue, it should be at least 5 mm margins. The only issue is again deep margin. So when you're cutting the muscles, the intrinsic or extrinsic muscles you're cutting, it immediately contracts. So there are various ways how you assess your deep margin in base tongue. But again, I will say more than 2 or 3 mm deep margin is okay for me. I cannot take 5 mm deep margin, whatever I try. If it is very superficial, exophytic tumor is okay, but it is inflated tumors, 2 mm, 3 mm deep margin for basting is okay, but mucosal margins, at least 5 mm, HPV negative, positive does not matter in our patients.
Great, great. No, so great thoughts. I don't want to send a message that you sort of stinge on your margins in any way. I think the larger message is that as you both of you all said, 5 millimeters of a microscopic free margin is something that we would sort of aim for. But what Dr. Dabas said is a very practical issue, especially in terms of tumors of this palate, and also you sort of see, and that's also the advantage of when you're doing in robotics. Now you're able to actually see very, very clearly, and of course, yeah, rather than using you can use certain anatomical landmarks like your constrictors, muscles, and if you're slightly good on that, then I think, and there is also a lot of literature also, at least to say that even there's some provocative literature to say that there's no tumor in the inked margin, you may be good also. So we are not getting into all those things, but this is work in progress. But for all practical purposes, try to achieve a 5 millimeter margin. Deepa, you want to add anything to the margin since you raised that question? Of
I think this is adequate summation for the students right now.
Perfect, perfect. Can we go to the next case? Srijan, we have time, right? How is it going? I'm just not having a tab.
15 minutes, sir.
2 minutes.
Okay. We will move pretty quickly. I think 67-year-old gentleman, again, it's right, this side, right side posterior 1/3 of tongue. I think I'll try to see if this video plays. Yeah, it's a sort of a exophytic tumor which was there in the base of the tongue. Again, your peripheral spaces were normal. Biopsy was squamous cell carcinoma grade 2, P16 negative. So I think we have discussed enough about the history and all the other things. Let's focus on the next 15 minutes on management per se. So in this case, it was sort of, I think I had the image also, I think, yeah. So these are some of the static relevant images. Just about, it's an exophytic tumor, seems to be little reaching towards the midline. Vessels are free, parapharyngeal spaces are free, and there are no nodes. Management directly, I think Dr. Rohit, you want to go first?
So in this case, I would like to go ahead with the TORS. Especially it has base of tongue lesions and tonsillar lesions are better operated with a TOR, can get better operated with TORs.
This was a 3.5 centimeters, I thought I told. Yeah. Dr. Andrela, and of course, you would do a neck dissection as well.
Yes, of course. I would like to add a neck dissection. Base of tongue lesions, more or less, will be more chances of bilateral. So I would like to go ahead with the bilateral neck dissection to level 2 to 4, and according to lymph positive, I will increase the levels.
Do you do any sort of what is the sequence of your surgeries, Dr. Rohit? Like you do the neck dissection.
So ipsilaterals, so first I would like to clear level 2, 3, and 4. If level 3 is positive, then I would like to clear level 5 also, sir. And level.
Yeah, go ahead. Anything else you do as a part of the neck dissection?
So Rohit,
sir, as a part of the neck dissection, as it is a base of the tongue tumor, I would like to ligate the posterior branch of the lingual arteries for getting a more avascular surgery.
Okay. Deepa, you wanted to add? Yeah, I was trying to.
So yeah, so Rohit, same thing. Why is vessel ligation important while doing TORS?
In the TORS, it will be a bloodless filled man. So ligating during the neck dissection makes the TORS surgery easier.
Is the ligation for the intraoperative field, or is it more for post-operative management?
Not sure, ma'am.
Andrela?
Intraoperative, ma'am.
Okay. How is the healing done in the post-operative period? How do you reconstruct these defects?
Ma'am, if it is a small tumor, we can leave the lesion for secondary healing also. We don't really need to reconstruct. As in this case, it is exophytic tumor, and we can leave it for secondary healing.
So what is the risk with secondary healing?
Secondary hemorrhage is a chance.
Right.
So
Right.
that's the most important thing, that during surgery, ligation of the facial branches and the lingual branches, even sometimes the ascending pharyngeal, is done to prevent secondary fatal hemorrhage in patients.
Perfect. Dr. Antala, do you also want to operate on this patient, or
Yes, sir.
base tongue 3.5 exophytic? Yeah. Okay.
Yes, sir. As it is an exophytic lesion and just reaching the midline, I would go for TORS if the patient particulars also match with the criteria for placing the patient under TORS.
Another criteria which is against going is 67-year age. Of course, the it's 70 years, which is usually considered, sir. CTRT, with the CTRT, it has been seen that after the 70-year age, the results are not seen, and the TORS will be better effective. Though there are no trials on it, it's one of the reasons which I would like to.
What data are you quoting to suggest that patients above 70 years do not benefit with chemotherapy?
One was the ECOG-ICRIN trial, which was done just on. I'm not able to remember the number of it, which is done just now, has shown. And the last trial was RTOG 0129, has also shown that with a no, ma'am, not RTOG 0129, ma'am. It was 9105, which had shown after age of 70 years, the results were not same. I'm not sure.
So it's not, it's the McKenzie data.
Yeah, ma'am, it's a McKenzie data. Yes, I'm sorry.
Okay, so the McKenzie meta-analysis which was done, which showed that patients above 70 years do not benefit and may have some harm from chemotherapy. So that's the reason. But recent data is not really fitting with that. And it's not a blanket rule that patients above 70 should not be offered chemoradiotherapy. So that's from McKenzie data.
Yes, and more importantly, this McKenzie data had patients only till 2012. It was, of course, an updated date analysis was published last year. So subsequently, you've had a lot of other things, of course. The other thing is that, you know, do you do any special selection criteria for patients for selection of TORS?
Yes, sir. Sir, here, if the patient is selected for TORS, then I would like to go for the biometric and cephalometric analysis for the patient to know about the mouth opening. In biometric analysis, I would like to grade the mouth opening according to the Mallampati classification, and also the neck circumference is taken into account, mandibular height, and also the hyomental distance. These four things are taken into account. And in the biometric analysis, we take into account the distance from the posterior pharyngeal wall to the hyoid bone.
This is what you said was biometric. Now you're telling cephalometric.
Sorry, sir. Yes. Yeah. Yes. So distance from the posterior pharyngeal wall to the hyoid bone, and also the inclination plane between the posterior pharyngeal wall, it should be greater than 130 degree. That is also taken into account.
Inclination from what? Epiglottis to?
Epiglottis to the posterior pharyngeal wall. Yes, sir.
No, not posterior pharyngeal.
Vertical plane of larynx.
Vertical
yes,
plane.
Yes.
And what is the third thing? Beautiful. I'm impressed, man. I'm really impressed by your thing. What is the third cephalometric that you would want to do? So between the posterior pharyngeal fall and the soft palate.
Soft palate, yes.
Do you do it, Rohit? Do you all do it routinely, or?
So we do it not routinely, sir, but we do it because we don't find that many cases. But whenever we find, we do it, sir. Usually, whatever, most of the time it's a advanced cancer, sir. So usually we have to send for psychiatry. But I have seen one TORS case getting operated for tonsillectomy.
Dr. Dabas, how do you select? I'm sure that with so much experience, from a practical perspective, do you advise every patient to undergo all these tests, or how do you sort of, I know these are elegantly described, and what is your advice and guidance?
Dr. Arvind, I was not using these criteria when I selecting doing TORS. Right. But then the papers came and they say these are the best way to just see the exposure. So why we want to do all these tests to have a good exposure? Right. So now I think myelopathy is the best way to see how good the mouth opening is. The rest of the things are theoretical, I can say that. So if you can ask the patient to expose the base tongue, you can see the base tongue through the oral route. I think the best patients for supraglottic tumors. For tonsil, I don't require this test. For base tongue, sometimes I require, but these all biometric, capillometric analysis is basically for supraglottic tumors if you want to go for surgery in these patients.
And possibly hypopharyngeal also, that odd T1, So
supraglottic. Then this is the best way to see the exposure. Again, if we're planning surgery, we always do an EUA. So if all these biometric, capillometric analysis is wasted, but yes, theoretically, we should tell our residents, they should discuss with the radiologist how to take these angles, these measurements, so that when you're taking the patient to OT, then you do a EUA. And that's the best way to see the feasibility of doing TORS.
Great. Deepa, what is your take? How is it that the selection at TMH, and what is your personal take on this?
So one is that always, as usual, it will be patient factors and tumor-related factors. For us, patient factors, like Dr. Dabas said, we would go by Malampati. We tend to do EUAs before planning them for surgery. So we have a separate GA in the minor operation theater where we take the patients under anesthesia. We evaluate the mouth opening. I also have started putting in a Boyle-Davis mouth gag that we don't have a FK retractor in the minor OT. So I use a surrogate of a Boyle-Davis, and that gives me an idea of how my exposure, especially for the lesions which are going lower down, will be. If the mouth opening is adequate, I think that with the Boyle-Davis, I'm going to get a good mouth, elevation, laryngeal elevation is proper. Then in these cases, we would go ahead for surgery. Again, now there are other patient-related factors. If the patient's got a lot of buck teeth, or the patient has trismus, these all again will make it very challenging to do robotic surgery. One thing which I have found in my personal experience is that unlike the Western population, Indian population does not have such a big, the greatest mouth opening. It's very challenging to put in that FK retractor. So it's basically made for Caucasian patients and not for Indians. So we have to use our own scales and criteria for it. And of course, tumor-related factors, especially for base tongue, when the lesion is obviously crossing the midline. Again, if I'm going to resect more than 2/3 of the base tongue mucosally, I will not offer TORS to these patients.
Right. Yeah. That's the functional component also. Say more than 50% of base tongue or postopharyngeal wall. Also, because it will be functionally mutilating also to these patients. And last question from my side, there are some 8 T's or something like that, no? So are you all aware of Indrila? Or Rohit, to you first. 8 T's of selection, no? It's a mnemonic, it's
8 Christmas you can remember now.
It's a mnemonic, and maybe Dr. Dabas will sort of,
for example, 4 in that.
So, for example, in the etiology of head neck cancers, you have 5 S's, no? So there is something called 8 T's or something of that sort. I'm sure, this is just a mnemonic, to remember, something is, say, prior treatment or something of that sort. So in trismus, teeth, tongue, tori. So like this, I think there are some 8 aspects of that. So this is very important in terms of patient selection. So that is also another aspect. And apart from that, you can divide into the other thing is also the vascular factors. Also, they've described some vascular factors. Are you aware of any vascular factors that are important?
Rectopharyngeal carotid artery, that is one.
Right. Dr. Dabas, have you encountered it in your practice? Or,
Theoretically, yes, but practically, you ask me, it is as a contraindication. It was a contraindication for tonsillar cancers. So now we have a conference in 2019. So there was this Dr. Bruce Huge. He was from US, and he was taking a lecture from contraindications to indications. So all the contraindications which were there in 2009, 2015, now they are becoming indications. So initially we started retropharyngeal carotid artery was a contraindication, but now you are doing a tonsillar tumor, even if T2, T3, T4 tumors in tonsillar cancers and N0 neck, they are going for surgery, and you find a retropharyngeal lymph node, you should always think about doing a reconstruction. But now you should know why you are doing surgery in these patients. Fine. So, and all contraindications are becoming indication nowadays, depending upon which type of patient you are selecting for. If surgery is required, then yes, in salvage settings, if patient has CA tonsil post radiation but it fails, now you're planning surgery. So in salvage, we always put a flap. So again, this patient will be a surgical patient, though he has a retropharyngeal artery, but again, we need a flap in this patient. So it is a contraindication theoretically till today. Yes, we should always see pre-operatively on MRI any retropharyngeal loop of carotid, because when you're doing surgery, it looks like a node, and you try to take it out and sometimes injure it, and you don't have a space to repair it at the time. You should always be aware, and you should go to the radiology department and just ask them to watch for it.
The final thing we have not touched about lasers, and this is something which is there as evidence is also. I think Dr. Oinrila, your take on lasers, like, so with so much the robotics has actually sort of taken over this space that since you also briefly mentioned that when robotics is available, you made a statement. So when robotics is not available in terms of lasers, are you aware of some of the evidences, or is it equally good? What is your take on it? And subsequently, Rohit, you can also add on to that.
Laser can be used, sir, but data and evidences I'm not very aware about, sir.
Rohit, your talk, because the talk should be complete.
TLM can be used, and TLM and TRS has seemed to be whatever the retrospective studies are there have shown similar results. In that sense, Nd:YAG laser is used.
Okay. In any laser you can do. Yep. Go ahead.
But, usually, sir, with 6 degrees of freedom, TRS being better. TLM has not come up with this one, and of course there are some. I have not seen TLM much more than that.
Deepa, what is your take on it? TLM.
So we in Tata use TLM mainly for laryngeal cancers. We don't use it for oropharyngeal cancers, and that's because we have the robot at our disposal. But Bruce Hoy's group has a lot of data on TLM for oropharyngeal cancers. The advantages are that it's very precise cut. With robotic, you're using the regular cautery, which will cause a lot of surrounding tissue damage and charring, which is avoided in a laser, which is more precise. But the problem with TLM for oropharyngeal cancers is that, one, you may have to cut through tumor and do a mosaic resection in those cases, because it's not possible to really do TLM en bloc resections in TLM. Which makes your pathology very difficult. So your pathologist will find it challenging to really report on mosaic resections. And the second, it takes a lot of time. It will take much more time than when you're doing transoral laser surgery, robotic surgery. TOLM will take more time simply because you have to cut through tumor. It takes time to cut through tumor, go through the layers, and then do layer by layer mosaic resection in these cases. At TMH, we don't have too much data or experience with TLM for oropharynx, but we use TLM routinely for supraglottic tumors.
Right. The last question from my side is it, have you seen open surgeries for oropharyngeal cancers, Rohit?
No, so I have not seen, because whatever cases we usually going for a CTRT. We are not finding this one.
So you have not seen any salvage surgery for oropharynx?
In my posting, I hadn't seen any salvage surgery, sir, but yes, there is a role of open salvage surgery when the after the CTRT if there is a recurrence.
Right. Dr. Angela,
Yes, sir. Upfront surgeries I have not seen, but salvage surgeries, yes, I have seen, sir. For the failed CTRT or.
I think in the interest of time, I think we've actually had an hour and maybe a slightly overshot time as well. Is it Srijan? I think it's time to wind up, right? I think I've got 3 more cases, but I guess we can sort of keep it for some other day. Any thoughts that we missed out, Deepa and Dr. Dabas? You can sort of let us know. And
so actually, not regarding to surgery, but strategies for de-escalation is something at least broadly we should touch upon once, I guess, to complete the discussion for oropharyngeal.
Yeah. Why don't you sort of give a small because at least now what I can tell is now even if you see the NCCN 2022 guidelines, no, it does not discriminate in terms of treatment with HPV positive or HPV negative, barring there will be slight differences because of the staging, adverse features, and all those things. But yes, it's a fantastic work in progress. Because I knew that there's so much of I think the retrospective evidences, phase 3 single institutions, Orator trial, Orator 2 trial. No, there's a lot of evidences, but I didn't really want to confuse. I thought Dr. Dabas may sort of run us through that. But your thoughts, Deepa, on de-escalation, the way forward.
So I think there's a lot of interesting data, especially for HPV positive oropharyngeal cancers. And this is basically for the students. HPV positive oropharyngeal cancers have survivals of above 90%. Now, when you have 5-year survivals about 90%, obviously you want to reduce treatment-related toxicity. And that's the reason why there's a lot of interest towards doing de-escalation or reducing morbidity of treatment. So there are basically 3 or 4 strategies to reduce the morbidity of treatment. One is to do surgery by TORS, and then do risk-based adjuvant therapy, so that not everyone receives chemoradiation, because chemoradiation comes with its own toxicity. So the ECOG-ACRIN trial, the 3111, is a very good example of risk-based TORS followed by risk-based adjuvant therapy. ADEPT and other PETHOS are other 2 trials which are going to come up in the near future. They are going to report their results in the next 2-3 years. The other strategy is to reduce from radiotherapy. You reduce it instead of giving cisplatin-based radiotherapy, you give cetuximab radiotherapy. But the de-escalate trial, this was to reduce the chemotoxicity. But the de-escalate trials and other trials which use cetuximab have shown that they are inferior in terms of control to cisplatin radiotherapy. So again, cisplatin-based radiotherapy stands the gold test of time, or is the standard treatment of choice when you're giving non-surgical modality of treatment. Now, there are other strategies as well by reducing the fractionation, doing altered regimens of radiotherapy. And all of this is basically with an idea to reduce the toxicity of treatment. So as students, you have to know the strategies for de-escalation, why we need to do de-escalation, and what are the current trials running. So a lot of good review articles are there on oropharyngeal cancers and strategies for de-escalation. Nature Oncology has good reviews. Just read up these articles. They summate them very well.
Yeah, absolutely. I think last year, I think, or earlier this, a couple of months back, also Nature Medicine had a review on this, I think. So abundant data. I think the thing in HPV positive, as Deepa said, we want to sort of know, because the prognosis is excellent, despite whatever you do, we wanted to de-escalate. And HPV negative, I think that is where our data is. And I think Dr. Dabas has extensively published over it. I think there is something to suggest that, we need to do a bit more for these patients, essentially, and that's why possibly, I guess, things might change. It's all work in progress. I think slowly surgery is sort of, especially the transoral robotic seems to have a slight edge, if I were made to say so, in the HPV negative cohort, both in the early stage cancers. Well, of course, in the advanced stages, more or less, I think there is a sort of an equipoise. What we need is definitely good quality Indian data. and more data on HPV negative part. If you see the literature, majority of them would be, even the orator trial, 86% of them were HPV positive patients. So you cannot sort of extrapolate that data to our sort of in a practice. And I think we should have our own sets of data and have our own evidences on this. Dr. Dabas, your final take.
Arvind, can I just interrupt in between?
Sure.
With the aim to actually look at this data or generate data on our own, we have proposed a multicentric trial in Tata Memorial along with Amrita and AIMS. We are looking for funding right now for that. This is basically on HPV negative oropharyngeal cancer, where we are comparing CTRT versus surgery followed by risk-based adjuvant therapy. So we'll watch this space. We'll keep you posted.
You can run it through IASO. Dr. Toprani is there. I think, you can run it, and I'm sure that, everybody interested would sort of, chime in.
Dr. Arvind sir and Dr. Nair, I think we'll request your comments on the students now. And following that, we'll hear Dr. Dabas's take on the management. First the moderator and then the examiners, sir.
No, I think they're really good. I think, so I really sort of like when students answer, and these two were really good, essentially. So I'm sure that all the best, and keep it up. Yeah, that's what. And try to sort of get. Of course, we didn't go more into evidences because I thought we have to. I tended to focus more on the technicalities of surgery. That's the very important aspect of the patient selection aspect and all those things. I felt that is more important. Evidences, most of you will be able to sort of read some review articles here, there, get all the information. So. And that is where you have to pick some tips from people like Deepa and Dr. Dabas. Keep it up.
Thank you, sir.
Dr. Nayak, your comments for the students?
I think Oindrila and Rohit did a great job. I was pleasantly surprised because oropharyngeal cancers is not a topic which surgical oncologists would look at it very interestedly, because as Dr. Toprani said right at the start, it's more a domain of the radiation oncologist, but you all have done very well. I think you all answered extremely well. So congratulations and all the best for exams.
Yeah. We request Dr. Krishnamurthy and Dr. Nair to stay till the end. We now hand over the mic to Dr. Dabas for his comments for the students, followed by his talk on management of oropharyngeal cancers. Dr. Dabas.
I would like to say that the robot is the one thing which is bringing back to the surgical oncologist into oropharyngeal management. So when I was in DNB student, oropharynx was my last thing I would study. But now you see these two students who is talking about oropharynx, they're talking about trials, they're talking about biometric analysis and cephalometric analysis. I'm surprised, seriously surprised, because I'm looking at this right now, not at this age when they're studying. So commendable job, guys, and wish you best of luck for your exams. Mainly Rohit, who's in exam going busy. But oropharynx was my last cup of tea when I was doing my surgical oncology practice. But now, maybe because of robotic system, we are talking about TORS, TORS. Now we are talking about surgical domain into oropharyngeal management. So that's why we are studying more about this.
We request now Dr. Dabas to kindly share your screen, and we'll be very eager to hear from you on the management.
So we have a lot of discussion about management of oropharyngeal cancers, controversies. See now, what is our aim of managing oropharyngeal cancers? The one, we want a good oncological outcomes, and same we want and good functional outcomes. So you know about the theoretical details of oropharyngeal cancers. Now it is rising into developing and developed world. We are talking about HPV negative cancers in developing world, and we are talking about HPV positive cancers in developed world. So you know the sites: tonsil, base tongue, postopharyngeal wall. Again, related to tobacco, not related to tobacco, related to HPV. There's so many things to discuss about oropharynx. So we have chemoradiation, the standard of care till today about oropharyngeal cancers management. till you don't find a way to treat them in a better way oncologically and functionally. So with the advent of robot and identification of HPV virus into oropharynx, we are talking about a lot about the management of oropharynx. So we should know what is HPV virus, what is HPV negative cancers, what is HPV positive cancers, how they behave differently. So, you know, we are dividing the oropharyngeal cancers. Now the staging is different for HPV negative cancers and HPV positive cancers. Based on HPV status, based on lymph node status, based on smoking history, we are dividing these cancers into low risk, intermediate risk, and high risk. So because of this, two things. So this was a famous study by Professor K. Yang. And now you see the difference. Why we are dividing oropharynx into HPV positive and HPV negative? Because HPV negative cancers are really bad cancers. They don't respond to chemoradiation so well as compared to HPV positive. And if you see the survival difference, see the PFS difference, see the relapse rate, at least a difference of 20 to 30% in HPV negative. They are more prone to recur. They are less cured, and they have high chances of spread elsewhere. So why we are treating these two cancers with chemoradiation, same dose of chemo, same dose of radiation therapy? Now we have started segregating them because we don't want to escalate our treatment for HPV positive, and we need to escalate our treatment for HPV negative patients. So we should de-escalate for HPV positive, we should escalate for HPV negative. So this is basically the stratification of oropharyngeal cancers based on PEC years, based on lymph node status, based on P16. And all matters, lymph node matters, smoking history matters, and HPV status matters. And see the survival difference between low risk, high risk, and intermediate risk. So you can see that P16 negative patients are mostly into high risk, except few early lesions like T1, T2, and T3. And HPV positive cancers are basically into low risk. And see the survival, 3 years survival for low risk is 94%, and for high risk is 42%, a difference of around 50%. So HPV positive, HPV negative, the difference is we are having young age who are affected with HPV positive cancers. So these patients comes at early T stage but higher end stage. Lower incidence of distant mets, second primary are rare, highly radiosensitive, and there's absence of field cancerizations. So why we are focusing on surgery in HPV positive? Because these patients have good survival, they have long life. So we should decrease the morbidity of the treatment, either as a surgical or a radiation arm. So that's why we want to avoid radiation therapy in these patients, because radiation therapy along with chemo has long-term side effects. But when you talk about HPV negative, we are older patients, locally advanced stage, higher chances of mets, second primary is very common, and field cancerization. So very difficult to treat HPV negative cancers, and again they're radio resistant. So now when robot came into 2006, people tried it in urology, cardiothoracic surgery, GI, but it was not accepted for head neck. So with great works from Dr. Weinstein, it was approved by FDA in 2009, but again only for T1 and T2 tumors. So we know what are the technical advantage of robotic system. Instrument endoris movement, magnification, no tremors. These are the technical advantage of robotic system. You do whatever surgery, they have technical advantage. But how they are important to oropharynx? They reach to the deepest area, magnified view, endoris instruments can take out the tumor, and block resection of the tumor can be done as compared to laser surgery. Laser surgery has basically limited vision. You cannot manipulate the tumor very well as compared to robotic surgery. You need to resect the tumor sometimes midway and take out the tumor into piecemeal, which is again we say oncologically not safe. So that's why we talk about robotic surgery more in oropharynx as compared to laser surgery in oropharynx. So we talk about laser surgery into laryngeal cancers, mainly vocal cord cancers. So now, based on HPV status, NCCN still says HPV does not change the management. But it is not far when they will say HPV changes the status. So now we talk about HPV positive and HPV negative. We know that we are talking about HPV positive because a lot of papers are coming from Western world where they have HPV positive cancers. We in Asian population have HPV negative cancers, but the papers are not coming from us. But we have to focus on HPV negative, which is, I will say, this is purely a surgical cancer. It's not a radiation cancer. So now we are talking about TORS plus minus radiation therapy in HPV positive. And we are talking about TORS plus radiation therapy plus minus chemoradiation therapy in HPV negative oropharyngeal cancers. So for early stage, either it HPV positive or HPV negative, I will say T1, T2, and 0 should be a surgical domain because the morbidity of this surgical domain is less. Oncologically, yes, it is having an advantage at least in HPV negative cancers because HPV negative cancers does not respond well to radiation therapy. But if you compare surgical arm with radiation arm in HPV positive, their cure rates are same. Why we are preferring surgery in these patients? Just to avoid morbidity of chemoradiation. But when you talk about HPV negative, the recurrence rate is more when you treat with chemoradiation as compared to surgery. So HPV negative early cancers has better survival and better functional outcomes. And we have done few papers on this and we have proved that, but we need some randomized studies for that. So now this is a multidisciplinary treatment. We should discuss our patients in tumor board based on T stage, based on his location, based on his relationship with the extremity, the surrounding structures, based on lymph node status, and then we should decide which is the best treatment for patients. So it's not only robotic surgery or chemoradiation we should discuss, but we should see the patient as a whole, which treatment can give them the better cure rates and functional outcomes. So you should have some indications and contraindication for all of the treatment for surgery, chemoradiation. Now, how we select? We should know what are the treatment-related toxicities, cost, survival, failure rate. So these are the factors where we should consider which treatment is best. So now we are talking about chemoradiations. We were talking about early toxicity. We are not talking about late toxicity. The famous trials where IMRT was used as radiation modality says that many patients don't tolerate chemo plus radiation. And the people who tolerate chemoradiations, they have long-term side effects in terms of pharyngeal dysfunctions, cranial nerve dysfunctions, and I think 43% patients have toxicity. So patient is cured, but with toxicities. So can we select any modality which can cure them with good functional outcomes? You can see the cranial neuropathy around 48%, which we don't look at it. So when the patient are coming to you, just always see patient is cured from cancer. But if you ask the patients, a lot of pain, aspiration, pharyngeal dysfunctions, there are a lot of things, and ORN is around 10%. So now, if you look at the data where we are seeing the oncological outcomes with chemoradiation, data says the outcomes are worse. This is one study where we have taken 314 patients and treated with radiation, chemoradiation, and you can see the 5-year survival is only 45%. See the relapse rate, very high. Metastatic rate, very high. So the outcomes are really bad, even you are selecting early cancers when patients are HPV negative. So now are we revolving? In past, in 90s, we were talking about surgery. then we came to radiation, then we came to chemoradiation. Now we are coming back to surgery. Is it possible? Yes, it is possible. So now with the endoscopic surgeries, you say laser surgery or TOS, we are coming back into surgery. So we are talking about intensification therapy for HPV negative and de-intensification for HPV positive. But the major work is being done on de-intensification in the Western world. Now we should focus on intensification therapy in Asian population where we have HPV negative cancers. Again, we have a lot of discussion in the class. Which cases should be selected for TOS? What should be the margin 3 mm and 5 mm? How you assess pathologically? So you need a surgeon to do robotic surgery. You need a pathologist to assess your specimen, because till now we can see that pathologists are not seeing oropharyngeal specimen. They need a good orientation of oropharyngeal anatomy and specimens so that they can do a frozen section or analysis on final paraffin. So a lot of cry was there on cost analysis, that robotic surgery is costly than CTRT, but analysis says that if you consider the cost from starting of the treatment till 30 days of completion of treatment, the cost analysis says surgery is cheaper than chemoradiation in all analysis. So multiple analysis has been done and all said that surgery is the cheapest arm. Even surgery followed by radiation is again cheaper. So a lot of studies came from Western world about surgery in oropharynx, and all said that the functional outcomes, if you select a patient wisely, are much better than chemoradiation, and even oncological outcomes are equivalent in HPV positive and better in HPV negative. Issue of margins we discussed in the class. Mucosal margins, deep margins. So we have a lot of discussion about this. Now this is the main which matters: swallowing outcomes, speech outcomes, muscular contracture, shoulder weakness, aesthetics. So these, when you compare, this is the functionality. All studies says that the functional outcomes are much better with surgery. Now you see this is a multi-centric study, and where I've highlighted, you can see that if you treat oropharyngeal cancers with surgery, either the patient is HPV negative or positive, or it is smoker or non-smoker, their survival are equivalent. But when you talk about treating this patient with chemoradiation, you can see with Kang study, their survival difference is at least 25%. So means it is oropharyngeal cancers are a surgical domain if you select your patients wisely. So a lot of studies has come about early or late oropharyngeal cancers treated with surgery and then radiation. And they again says if it is HPV negative cancers and you treat them with surgery followed radiation therapy, their outcomes are much better than chemoradiation. Next. So this is a multicentric analysis again, and all studies says that they talk about tracheostomy rate, they talk about PEG rates. So at the end of 6 months, your patients are PEG free or tracheostomy free. So the functional outcomes are better, but it was in the early learning curve of surgery when people were learning robotic surgery. Now rarely you require a tracheostomy for early oropharyngeal cancers. Why tracheostomy is required? Why, when we should do it? I will always say salvage patients, yes, and supraglottic tumors, yes, for exposure. Otherwise, you can avoid tracheostomy, and doing a tracheostomy hampers or weakens your functional outcomes. So this is our study when we're starting doing robotic surgery, and can we do robotic surgery? Do we need to convert the patients when you're doing transvaginal robotic surgery? So we have done studies in all set of patients, T1, T2, oropharyngeal, HPV negative, salvage patients, T1, T2 with node positive oropharyngeal cancers. And what we have seen that the oncological outcomes, if you do surgery in early oropharyngeal cancers, are much better. when you do surgery in node-positive oropharynx, which are HPV negative, then followed by radiation therapy, again the functional outcome are good. The only issue is when you do surgery in advanced oropharyngeal cancers, which are T1, T2 with node positive, and patient require post-operative chemoradiation. So their functionality takes time to recover to come to the base level, but their oncological outcomes are again better. So when you talk about HPV positive cancers, we talk about functionality. But when we talk about HPV negative cancers, we should talk about oncological outcomes plus functionality. This has been highlighted by Dr. Deepa in the class about de-escalation for HPV positive. There are a lot of trials are coming, pathos, ECOG, and all are saying that in HPV positive cancers, we should decrease the dose of radiation therapy. Studies are very few on HPV negative cancers. We have done, done few trials, few studies on HPV negative early cancers. This is the early cancer study where we have taken around 57 patients, but 49 patients were taken in the studies. 8 were excluded where they were node positive, and it was superb oncological outcomes. Now, how you intensify your treatment for HPV negative cancers? Again, I'm telling you about do surgery in selected patients. Oropharyngeal cancer should be T1, T2, or sometimes exophytic T3, node maybe N1, N2, and do surgery because the morbidity of the procedure is oropharyngeal resection, not the neck dissection mainly. So if you're taking early cancer from oropharynx and then giving radiation therapy, your functionality will be better. So now a lot of trials are coming where what they are doing, they are dissecting the oropharyngeal cancer with good margins, and even in node positive, they are trying to avoid and boost to the primary or avoiding radiation therapy to the primary. If in future we are able to do that, then the functionality is going to be much better and the oncological outcomes will be better. This is in stage 3 and 4, not stage 3 and 4 because T3 and T4 because of node status. And again, we have shown that we have taken good number of patients, and what says that again, oncological outcomes are good and functional outcomes are good. So if from this class we want to take some messages, the one message is that T1, T2 oropharyngeal cancers, either it is HPV positive or HPV negative, we should give both the option to the patient, surgery versus chemoradiation, then the patient should choose. If patient had good mouth opening, younger patients, I would always lean towards surgery for these patients. Then we talk about T1, T2, N plus disease. And if we want to do some advance into radiation technique, then I will say we should go for surgery in at least who are HPV negative. So improve their surgical outcomes. And patients who are HPV positive, again, we should advise surgery and decrease the dose of radiation therapy or avoid radiation therapy in at least N1 disease. But main dilemma is that when you have an advanced nodal disease, I will say N2, N2C or N3, I don't advise any surgery in N3 because they mainly fails distantly. But the patient who requires surgery and then chemoradiation, that is the main challenge in managing the oropharynx. Their functional outcomes are not so good. In future, if we can decrease the dose of radiation therapy in these patients, because still we are following the same protocols which are being followed in oral cancers. If you are doing an adjuvant radiation therapy in oral cancers, you always go up to 66 gray. So can we decrease the radiation therapy? Can we decrease the field of radiation therapy in oropharynx? Maybe in future we can improve the functionality at least in post-surgery patients of oropharynx, and that is the motto of our treatment in oropharynx. So are we still roaming around surgery, radiation, chemoradiation, and surgery again? So this is the, I think if you talk about any conference into head and neck, this is the hot debate, TORS versus chemoradiation or radiation. Why? because we know we have to improve our outcomes, and the only way to improve our outcomes is let's start doing this and see how the outcomes are there. So this is from my side, and any query can be answered.
Thank you, Dr. Dabas, for that excellent talk. This brings us to the last segment of this webinar, which is Q&A with the experts. So most of the questions seems to be answered on the chat box as well as in the discussion. We have 3 questions remaining. So I've posted these questions to particular examiners. However, others are also welcome to chip in. Our first question is to Dr. Deepa Nair. The question is that in a P16 positive carcinoma unknown primary with a mets to the neck, what's the role of tonsillectomy in these patients?
So there's emerging role, and there's a lot of robotic data which shows that if you have a P16 unknown primary in the neck node, then doing a tonsillectomy will actually find tumor and upstage the disease in around 20 to 30% of the cases. So the advantage of this approach is that you are finding the primary, that again helps you reduce the dose of radiotherapy, because these patients will have metastasis to the neck. So they will require adjuvant radiotherapy, but you can tailor your radiotherapy and the IMRT to only the involved tonsil, and that helps reduce the dose toxicity to the DARS, dysphagia aspiration related structures. So for patients who are P16 positive or HPV positive, there's a trend towards recommending doing tonsillectomies even for unknown primaries, with an increase in the finding of the primary of almost 30% of these patients, which is additional to the PET CT scan, which has already been done.
Thank you, Dr. Nair. Any inputs from Dr. Krishnamurthy and Dr. Dabas?
Dr. Srijan, can I just for a discussion, Dr. Deepa?
Yes, Dr. Dabas.
So I always ask people, when you're treating any T1 tongue, we do surgery, and if the neck nodes are negative, we don't radiate the patient most of the time.
Yes.
So when you are doing T1 tonsil, we find in unknown primary, and we are done tonsillectomy plus the neck dissection. Why don't we avoid radiation therapy to the local area, the tonsil? Because that is the main area of morbidity in our patients when you give radiation to the constrictors.
So
T1 resected very well with good margins. And I think we are not doing the study either it's HPV positive or negative, but in HPV positive, people have done studies and they say, yes, we should avoid.
Yes,
but why we cannot avoid when you are not doing any radiation therapy in T1 lesions?
So there are studies which actually look at the subgroup of patients where the primary is small and has been resected with good margins. And I'm not sure, I can't remember the name of the study off my head, but there are studies, if I'm not, no, it's not the Top Rock study. There are studies which look at avoiding radiation for the primary completely and only treating the neck with radiotherapy. So yes, there is data which will emerge, and we'll actually see whether the outcomes are similar to radiating both primary and the neck. So until we have evidence, I think it's my opinion versus yours, but evidence is always irrefutable.
The other thing I just wanted to add is, supposing you find a primary, then it's no longer an unknown primary. So you treat it as a known primary. So in which case, so you will not radiate the sense. Only in case of unknown primaries, now you may sort of want to do that. So if you are finding a primary in the oropharynx, then you sort of treat it as a carcinoma oropharynx P16 positive, whatever you would do otherwise you would do in these patients. And again, to answer to Deepa, yes, I think there are some provocative studies to avoid radiation therapy in cases of oropharyngeal cancers. That is to avoid the radiation to the primary and just try to do the neck. So, but again, in an attempt to possibly de-escalate.
Dr. Arvind, they're not giving radiation therapy to the primary, but they're giving boost to the primary also. That's a problem. If you don't give boost, I'm happy with that. radiation up to 45 gray is okay, but giving boost to the local area which you have resected is increasing your morbidity.
Right.
So I think we should get a radiation oncologist next time to discuss the technicalities here.
Yeah.
So we'll go to the next question, which is post chemoradiation, when and how to reassess, and would there be a imaging of choice in that setting? To you, Dr. Arvind Krishnamurthy, sir.
Yeah, I think this would be the standard for any post CTRT. We would sort of, clinically assess them at some 6 weeks or so. And if the continued state of remission is there, then you try to do a PET CT at 3 months, that is 12 weeks, and then take a call based on the PET CT. So the standard functional assessment would be a PET CT at the end of 3 months. But in case you have the patient is showing any signs of sort of disease or otherwise, you can sort of clinically assess the patient and do imaging other than. So you can otherwise do CT or MRI earlier as well to assess the trajectory of the patient and the disease.
So the question which was also presented in the previous masterclass was, would you, after clinical examination, would you do a biopsy first before doing for a PET, or do a PET and then plan on a biopsy?
In which scenario? Come again? At what time interval?
At 3 months or 6 months, sir. Would you go for
a? We would do a PET, and the PET directed sort of
directed biopsy.
Yeah,
perfect.
Not biopsy in the sense like you based on your PET finding, you would sort of take a call on whether to biopsy or not. Like it's not that you should always biopsy to sort of to confirm the remission. Yeah, Deepa, you had something.
I was just adding a point that your biopsy itself will induce inflammation, which will light up on a PET scan. So it always makes sense to do the PET and then target your biopsy to avoid these inflammatory changes, which will light up on a PET.
This brings us to the last question for today, and that is to Dr. Dabas, which is, what is the rehabilitation program at your institute for patients undergoing these surgeries?
Yeah, Dr. Sridhan, this is the best, or I guess this is the most important part of any oropharyngeal surgery, that is rehabilitation program for these patients. So unlike the oral cancers, when you do surgery in oropharynx, the patients are very prone to aspirate. Or I can say the secondary hemorrhages are much common when you do an oropharyngeal surgery. So in this, the rehabilitative program talking about speech and swallowing therapy, and mainly the swallowing therapy. So any team which want to do a robotic surgery should have a swallowing therapist. And we have swallowing therapist team of around 5 people. So what is our protocol? If you do surgery for tonsil, day 3 and day 4, we start with oral soft diet. If it is a base tongue tumor, we start giving soft diet on day 5 or 6. But for supraglottic tumors, we don't start any diet before 10 days. This is our rehabilitation program for any of the surgery done by robot for base tongue, tonsil, and supraglottic cancers.
I would like to thank all the 3 examiners for this very engaging webinar today. Thank you for patiently answering all the questions which were come up in the chat as well as on the For the Expert section. I invite Dr. T.S. Rao to kindly deliver the vote of thanks for today's webinar.
Thank you, Srajan. I'm sorry, I'm traveling, so there may be some disturbance. But I think what is distinct about this 2-hour session is the wonderful coordination between the examiners and an excellent performance by both the students. Arvind Krishnamurthy, I'm not surprised that he has moderated really well. And he has made put in a lot of effort to make excellent case capsules, and he really got the 2 examiners going and got the best out of the students. Truly appreciate his presence. Surendra Dabas, he's an expert in this field. So the expert talk was excellent, and then his participation in the examination also was something that will remain heard by students on YouTube. Divana is somebody I've never heard, but very impressed with her presence and performance in this 2-hour session. And I think this particular session will be seen and heard on the YouTube by thousands of people in future. I was very impressed with this 2-hour session. Thank you very much, the examiners, and a special thanks to the young students. Srajan, a pat on your back for all the hard work that you've been doing all through. Thank you very much. IASO, on behalf of the Academic Council, we thank you for reposing confidence on the Academic Council, and we hope to do our best in the future. Thank you. Good night, all of you. Next session, Srajan, please announce the next one.
Yeah, so our next section is going to be on the 5th of May, Thursday, same time, 7 p.m. And the topic is going to be G-junction tumors. We thank everyone for their participation. Good night, everyone. Stay safe. Thank you.
Right.
Thank you. Bye-bye.
Bye. Bye.